This is Medically Speaking. I'm Dr. Eve Glazier. If you or someone you love has ever been admitted to the hospital, you've likely met a hospitalist. And like most people, you probably have never heard the term hospitalist before and almost certainly did not know what it meant. So you may also recall that in a past episode, we talked about primary care clinicians, like myself, as your home base, your quarterback, or for my orchestra nerds out there like me, your conductor. So think of a hospitalist as the on-field quarterback inside the hospital, coordinating the team, keeping the plan on track, and helping you get safely home. So today on Medically Speaking, the hospitalist, what they do, why this role exists, and how families can stay organized when the days blur together. I'm thrilled to be joined by Dr. Ashley Busuttil, hospitalist at UCLA Health and Chief Medical Officer of Ronald Reagan Medical Center. Fun fact, Ashley and I have known each other since junior high, and yes, we were on the dance team together. Ashley, welcome to the pod.
Thank you, Eve. I'm thrilled to be here.
So Ashley, let's just start with the basics.
Okay.
What exactly is a hospitalist?
So I do think your introduction was quite on point with referring to a hospitalist as your quarterback, but inside the hospital as opposed to inside the clinic. Hospital medicine actually has been around for some time. It started back in the late 90s and even before then in a lot of health systems in Europe. But it's interesting to me that not a lot of people, know the term. And what happened back in the 90s is healthcare costs were really skyrocketing. That was coming to the forefront of everybody's attention. And hospitals realized that they really needed to make sure that the care of their patients while they were in the hospital was really efficient. And the old model was primary care doctors would wake up in the morning, they would, go see whatever patients they had that happened to be hospitalized in the hospital. They would go to their clinic, they would stay in their clinic all day, and then maybe they would go back to the hospital in the evening and see those patients. So it was not really 24/7 care for those that were the sickest in the hospital. And I think if you're a patient, you want your doctor to be available. So hospitals realized that they really wanted somebody on site there all the time, being able to address the changes that patients were undergoing, while they were there. And I think the second component is medical care has just frankly gotten more complex. There's so much innovation. It's just so much bigger than like when you and I trained.
Exactly.
And I think about what you do in the clinic, it's such a different skill set. It's such different, medicine than what I do in the hospital for a patient who's there for, a more acute illness.
I mean, I couldn't agree more. It terrifies me to think about doing what you do. And I think for our listeners, so Ashley and I both completed a residency in internal medicine. So we completed 3 years of 90 hours a week, right? Training. We studied adult medicine in both a clinic setting and hospital. We also completed a year of chief residence because we're so superstar. Then I went to practice in an outpatient primary care setting, and you became a hospitalist. And it's interesting because even today, you and I sit next to each other at work. I really wouldn't know how to be a hospitalist. The medicine has gotten so complex. And granted, we both work at UCLA where it's what we call a tertiary quaternary center, right? The most complex patients, right, who are there for transplants, you can go into the medicine versus what I do in the clinic, right, doing preventative medicine. But it's really we really bifurcated, and I really don't know how to practice that medicine. It is very, very complex. You prescribe antibiotics, you work with teams that I just don't do in the primary care setting. So I think it's so helpful for our patients and listeners to know that's right. The old school way of if I'm a primary care doc, I'm going to round on patients and then go to clinic. Not only do I not want to do that, that's honestly not part of the work-life balance that I'm signing up for, but also I'm just not equipped intellectually to take care of patients in the hospital. So we have this partnership even around general medicine. So it's helpful to hear about that, the shift. I guess I think all of our listeners might want to know this is having a hospitalist, is that sort of the best practice? Is that common among hospitals across our nation?
I really think it's almost becoming the standard of care. And by that, that means the way everybody is practicing now. When you think about patients who are hospitalized and how to care for them. And just to go back briefly to what you said, I mean, likewise, as a hospitalist, I don't know how to do the things that you're doing. So things around complex conversations around, like, say, screening colonoscopies, or things that you're really projecting out, far for your patients. I'm concentrated more on their acute setting. But yes, I do think it's becoming the standard of care, because again, you want someone who is there all the time, who is not trying to, listen to what's going on from a phone call, across the city and call in orders, while they got a patient in their clinic, right? You want someone who's there. You also really want to think about the relationships of the entire care team in the hospital. So I know the nurses, I know the consultants, I know who I need to call, I know how to quickly and efficiently get things done and keep patients safe and progressing through their care. Yeah. And if you're not there all the time, you can't do that.
I thought it might be helpful just to kind of describe exactly what hospitalists do, what you do, by maybe even walking through a patient journey. So from, let's say, admission, whether that's through the emergency department or direct admission, and we can define those things for everybody, to the day-to-day of a hospital stay, and then finally to a safe discharge. Does that sound okay?
Yeah, sure. So I'm going to take a little bit of, there's some complexity around how hospitalists are scheduled. So, for example, it may not be the same person that meets the patient in the emergency room to be the one that takes care of them throughout their stay. That has to do with the ebb and flow of patients and just how the size of a group may be, organized. So I'm just going to take that out for a minute. But if you think about it, what will happen? A patient, let's say they have an acute illness, they've got abdominal pain. Mm-hmm. They come into the emergency room, they get diagnosed with something, by the emergency room doctor, or maybe they don't even get diagnosed. Maybe they just get sort of stabilized, and really the decision is made, you need to be admitted to the hospital. They'll then call a hospitalist. The hospitalist will come down, evaluate them, decide, you need, speak to them, you need X, Y, or Z tests, mm-hmm. and then they move up to whatever room in the hospital that's appropriate for them. From then, they stay in the hospital for the duration of their care. The hospitals will decide if they need to have a consultant on board. Let's say they need to have a, cardiologist see them. Let's say they need to have multiple consultants, a cardiologist, a rheumatologist. The hospitalist's then job is to see them every day, or as many times as necessary through the day, coordinate the recommendations from any specialist, or if they don't need specialists, come up with a plan of care themselves, make sure they're communicating that care to mm-hmm. the patient, and then when they're ready to leave the hospital, coordinate with their primary care physician or whatever outpatient physicians that they need, and do what we call that handoff. And we may get into it probably, but the two, I think, most critical times of, a person's hospitalization are when they come in and then when they leave. And to make sure that the care is seamless across those transitions, seamless with regard to their education, seamless with regard to the medications that they need, that they can pick up those medications, mm-hmm. they have their appointments and follow-up, and so on and so forth.
So starting then with the handoffs, what can we advise maybe patients and families, I guess, around, let's say, that first transition or handoff, right? So whether it's in the emergency department, it's hard, right? If you're going to the emergency department, right, and there's urgency, it's hard to remember everything that you need. But anything that you would recommend patients or families bring to the emergency room, just that might make that ease of and safety, I guess, of transition. Yeah.
Well, let me take a step back for a second and just comment on, when you think about these transitions, I could take care of everything that needed to be taken care of in a hospital setting, all the right medications, all the right interventions, whatever it might be, you could be feeling, great. But if I don't set you up in a way that you are then able to continue that right. care once you leave.
Yes.
Again, obtain your medications, know what diet you need to do, know what kind of rest you need, all that stuff, and there's so much of it, you're not going to do well. So it basically, takes away all all the, stellar work that happened in the hospital.
Don't make Ashley look bad. Right.
So again, that's to just sort of take a step back and highlight the importance of those transitions. But back to your question, what can families know? That when you're coming into an emergency room, that can be chaotic.
Yes.
I get that. But things that are important is knowing what medications you or your family member take. Having a contact and an advocate for the person and by that I mean somebody who maybe knows something about your medical problems. If let's say you're a daughter or a son taking care of your parent, knowing your parent's medical problems, at least generally,
right.
Knowing who their outpatient physicians are, and almost most importantly, having a sense of what your loved one wants kind of for their health care. That's a big topic, but those are the kind of things that I'm going to want to know when I evaluate a patient when they come in. What was their sort of day-to-day life before? How does the situation, the medical situation that they're in now compare with that? In addition to those more, medical things like what are the medications, what exactly conditions do they have, and so forth.
No, that's perfect. And then, so walk us through, I guess, a typical day for you then. So the patient has, our patient has been admitted, you're the assigned hospitalist. What's your typical day then in your role?
So I work as a academic teaching hospitalist. So that's, I say that because I think families who come to UCLA do need to be aware that there's a lot of people that come in and out
Yes.
of the room. And by an academic teaching hospitalist, what I mean is I work with resident trainees and I, educate them through our care of the patients. So in the morning, a patient who's, hospitalized on my team, or I am the primary doctor responsible for them. However, they may have an intern, which is a first-year resident who comes in there early in the morning to see them. We remember that from when we were, a good deal younger.
It was like 3 years ago.
It was like 3 years ago, so much younger. That intern will probably come in the morning. There's a more senior resident on the team. And what I do is I come in, I usually look through the medical records. I'm, seeing what do their labs look like for the morning? What were their vital signs? How did they do overnight? What have the nurses said about how they do? And I'm kind of collecting all that data. Then I will hear about how they're doing from the residents. And this is the major teaching component for the residents. We're talking through all our patients' care. We might have, for perspective, somewhere between 10 to 20 patients in the hospital at a given time. By we, I mean...
On the hospital's team.
Right,
Yeah.
me and my team. And we'll talk through all of them. We prioritize people by, if there's anything that's concerning about their care in terms of they're sicker than we anticipate, there's something going on, they're not doing as well as we thought. And then also by those who, might be going home because of all the complexities around that I sort of mentioned. And then I'll go around and see them, one by one, and we'll sit down and we'll talk about how they're feeling. We'll talk about what's going to happen for their day. We'll talk about any concerns that they may have. I like to project out several days and really talk to patients about what can you anticipate certainly for today, but for the next few days of your hospitalization, and then the next, phase of your care after that.
So it has to be so comforting, though, to set that expectation. I mean, like you're mentioning, there are so many people coming in and out of your room and you're hospitalized.
Oh,
and
my
I think
goodness.
all of us have either been patients or our family members have been patients, and it's really overwhelming. It's stressful. I mean, you're usually not in the hospital because you feel great. It's not.
Yeah.
It's not the Four Seasons, and you're not sleeping well. You're probably hungry. You're in pain. You probably are worried. There's uncertainty. So it's really helpful for you to articulate and kind of itemize all the people on the team. Those are all the people walking in. And again, that's your hospitalist team. If there's consultants, are there other people besides your team with residents that are coming in?
Yeah. And I think you're absolutely right. It is so overwhelming for people to be sick and see all these faces. I mean, this really came to light, for example, during, the thick of the COVID pandemic when everybody was wearing masks and gowns and you can't tell how terrifying for a patient, right?
It's awful.
I do always really make a point of every time I come in, I say, hi, I'm, Ashley Busuttil. I'm the supervising doctor on your team. I really always introduce myself, even if I've been in, however many times before,
Yeah.
because you just can't expect anyone to necessarily keep track of those things. And it's important for us to let people know who we are, what we're going to be doing, what our role on the team is. Other people on the team, so of course there's the patient's primary nurse, which if anyone's been in any kind of hospital setting, you just know how critical, your relationship is with your nurse. That's someone who's going to be there, basically throughout the day for you. For perspective, a hospitalist may have, again, 10 to 20 patients that they're seeing, at a given time. The nurse will be taking care of 3 to 4. And so that individual, that nurse, is really going to be in the room, sort of almost constantly with those patients, working with them on their needs, and also helping with a lot of the educational part, of their care. Other members would be what we call the care coordinator, which is a case manager or sometimes a social worker, both. And those are individuals who help with a lot of the social aspects of a patient's care. Are they having problems with their finances? Are there other aspects that it really impact their health that we can help with? Are people having food insecurity? Are people having issues with transportation? I mean, there's so many aspects. And then, the case manager is the person that will do a lot of the logistical work, helping that individual move to the next phase of their care. And then there'll be the medical physician consultants as well. So, I mean, this is just a huge number of people. So what I like to do, with patients is, say, let them know who I am and say, okay, today, for example, we're having a cardiologist come see you. I'm asking them to see you because, I'm concerned you may have had a heart attack or whatever it might be. And I like to really help that patient understand what the role of each of the consultants is, because the consultants are really focused on their area of expertise, right? And the hospitalist is there to bring it all together for that patient.
Which is amazing. And I mean, it's very reassuring and obviously amazing to hear that you lay this all out, right? And you're coordinating and you're explaining. For patients and families, if they have questions, can we encourage them to ask, what's the plan for today?
Oh, absolutely. Okay. Absolutely. It's really critical that they be aware. Now, I do always let them know this is a dynamic, situation, based on, how the individual does. The plan today might not be the plan tomorrow, but we always can and should be, planning out and working with patients to ensure that they not only that they understand, that they're participating, right? They need to understand and be involved and agree with what we're doing.
What's the best way then, would you say, for them to be involved? I mean, is it like someone's taking notes? Is it a daily log? I
mean, I think that depends on the individual, and it depends. I mean, it's so personalized, right? There are some people who really like to know about, every test and every, everything. And, now, with our electronic health record, people actually can look on their phone and have all
in real time.
Yeah, in real time, and see the notes and look at the labs and all the stuff. So I think it depends. Other people are sort of like, I want big picture. Tell me, just give me the kind of the big picture view. Right. One thing that I find very helpful, and I think for your listeners, this is a good way to think of a hospitalization, is, how sometimes you're dealing with some really, dramatic situation, and you almost don't know what the big picture is at all. It's just hard to wrap your head around it. I like to help them scope out what is the goal of this hospitalization, right? It's not always for you to feel perfect when you leave, right? There are people who have chronic illnesses that may be going on. There are people who may not even have a diagnosis by the time they leave a hospital, which that's so frustrating and scary, right, for people. So explaining, okay, our goal here, for example, is to get your symptoms under control and make sure that you are set up to see the right person who will do X, Y, or Z testing to get you to that diagnosis. And so that goal of the hospitalization is quite different from one case to the next. And I think that is really important for people to understand, so they can kind of wrap their head around this like really, scary experience that they're going through.
I think that's such a critical message, and it reminds me that I feel very lucky to work in our health system, and I say, I'm not going to take care of you in the hospital, but the hospitalists are all my colleagues, right? And so I know exactly what's happening in the hospital, so that when you're discharged, when this episode of care, right, those symptoms are controlled. You might be admitted just to have your pain controlled, right?
Yeah.
But then there's a handoff back to me as a primary care doc. There's a handoff back to specialists that will keep on continuing your care. So I think the setting of the expectations is really important. And you're right, maybe not every question is answered, but symptoms will be alleviated, and it's to get you home, or let's say to a facility, so that you can continue to heal.
Yeah.
Sometimes I do feel like with all the people coming in and out, patients and their families aren't sure that the plan is unified, and I'm guessing that's where you come in.
Yes, I will say that is a challenge. That is a challenge in, I think, any hospital system, and certainly, in the one that I work in. So I consider that to be one of my, primary, responsibilities and goals. It's a balance, right? When people are coming in and out of the hospital room at all different times during the day. The cardiology team has a different schedule than the, primary hospital medicine team, than the rheumatology team, right? And the team members all want to give the patients as much information as they can. The patients always want as much information as they can, obviously, but that leaves them getting some of the information piecemeal.
Yes.
So it is definitely the hospitalist's job, and often this might be circling back, for example, at the end of the day to sort of say, okay, we talked about the plan in the morning, which was that the cardiologist was going to come in, the rheumatologist is going to come in. Now we've got all that information. Let's review and kind of synthesize this and see where we are now.
Right.
And so doing that, periodically with your patients is really critical. So usually for me, at minimum, I am seeing them in the morning and, in the evening, or, a team member is, or whatever it is. Again, of course, more if needed, but just to kind of, pull everything together so that they understand where we're getting.
I mean, the communication sounds essential. So discharge, which means leaving the hospital, how do you decide when someone is ready? I mean, it sounds like you're looking ahead and projecting, but what are some of, I guess, those endpoints?
So obviously there's, medical stability, that they no longer need, the services, in a hospital. And so that would include, for your listeners, the kind of things that, happen in a hospital that we often don't do at home. Or one, if someone's like their health trajectory isn't clear. I don't know if they're going to be sicker tomorrow than they are, than they are today.
They're not stable.
Right, exactly.
They medical need to be, jargon. Yeah.
They need to be stable. The second is just simply, needing, a good deal of nursing care, for example. They need somebody to be with them because they're not safe. The third is, medical interventions, whether that be, IV type medications that can't be given at home, frequent, diagnostic tests, a whole host of things. So they need to be medically stable, as you said. And then they need to have a safe discharge plan. And by that, I mean, if I have someone, for example, who is elderly and they live alone, maybe they're medically stable, but I'm trying to picture them in their home setting. Right. I know they don't have any help, and I know they're not going to be able to get out of their bed, make food, get safely from, whatever, the bed to the toilet, do the stuff of life. Then my job, working with the, case manager and care coordinators, to say, okay, how can we get them into a, safe home situation? So it's really two main issues: medically stable and safe place to be afterwards. Actually, one third thing is making sure that remember I said that we have necessary, a follow-up after they leave the hospital.
Yes.
By that I mean clinic appointments, whatever. Part of that safe, home situation is that they're able to, get to those appointments, and that the necessary follow-up care is, established, or at least we have a path, towards it.
It's incredibly complex. I mean, I think, and I guess the only way to really talk about it is to explain it and to constantly communicate, because you're absolutely right. I mean, your pneumonia might be better, right? You might not be coughing anymore. Your vital signs, which by that we mean blood pressure, temperature, how well you're oxygenating, your pulse, all those might be normal. But exactly, if you can't go home and feed yourself or get to the bathroom, then you're not actually stable, and then you're just going to come back to the emergency room.
Right. So for your listeners, one of the things how I kind of like to phrase it to patients and their families is, think about how you are here in this hospital bed and your hospital room, and the services you're getting, and now picture yourself at home. Mm-hmm. How do you think that's going to go for you? What do you think you'll be able to, in the way you feel now, do the things that you need to do for your daily life? And that might not be initially, popping out and doing some,
Soul cycle.
Right, soul cycle. But are you going to be safe? And in terms of when we were talking earlier about sort of, being an advocate as a family member, for your loved one who's in the hospital, I like them to be there, for example, for physical therapy, for occupational therapy, to be paying attention to, do they need to be fed? Can they do it themselves? That family member may be thinking about, what does my mom's home situation look like? Is she going to be able to do this stuff? Is she going to be safe? And that's really a partnership to figure out how to get to that next step, right? Is the family member going to, stay with their loved one for a time in the house? Do they need to, and it's a whole nother topic maybe, but do they need to have, go to a, rehab facility for a period of time, hopefully as a stepping stone to getting home? And the case manager will be working with the families and the patients to really do a standard assessment of their home situation and their home needs. Do they need medical equipment, all that kind of stuff is really a conversation, and again, a partnership with the patient and the family. And it also brings us back to that idea of this is a joint venture with the patient. Right. I mean, the patients are the most important people here to be a part of this conversation. Do
you feel like when patients are, they come in quite ill usually? I mean, for them to get admitted means that they're pretty ill. Mm-hmm. Any advice for how they can be advocates for themselves? I mean, again, I'm sensitive to the fact that they don't feel great usually, but for their families, it's hard to just keep track of all the information. How are they going to feel reassured, I guess, for this critical handoff of being discharged, of leaving the hospital, transitioning out?
I think it's important for people who are, ill like that to recognize maybe some of their limitations and when they need, a family member or a friend to really help them. I mean, I always think about it, you're in the hospital, there's stuff going on through the night. You might be left without eating because you have some procedure and you're not allowed to eat.
Exactly.
You're in, potentially hospital garb. You're not feeling your best, right?
No.
You're not... you're not at your primary decision-making,
exactly. No,
place.
exactly.
Very hard. So I think maybe having compassion for yourself and realizing, when you need to ask for help, a partner to kind of hear the medical advice. Even you can say to your doctor, I need someone else to participate in this. Can you call my daughter? Whatever it is.
That's actually my next question, because I think, you mentioned coming in right during rounds. That's our super doctor word, right? We rounding in the morning, and it's usually it's 7. First of all, it can be any time, but often it's quite early. Surgeons round very early.
Very early.
So sometimes family members, right, are by their loved ones' bedsides.
Yeah.
Sometimes patients are awake, and with it. But let's say someone's not there. What do you tell the families in terms of if they're like, Dr. Busuttil, I want to talk to you later in the day. Can I call you from work to get an update? Is that something they can ask for?
Absolutely. And I want to all of this stuff, by the way, should be standard. Our goal is really for, patients to not have to remember anything. I don't mean the medical care, but I mean I don't want it to be on the patient to say, oh, I need to ask for X amount of communication or whatever. Nevertheless, having a clear phone, who is the primary, person that you want this doctor to be speaking with? Is it a family member? Is it the patient? If it's the patient, do they want to bring a family member, in with it? When do you want that to be? Now, there is a lot of stuff going on in the hospital, so you may find a doctor saying, I can't just call you back any time of the day.
Yes.
But you can certainly say, hey, can we establish a goal, standard time every day for us to touch base?
Okay,
that
good.
is 100%. Often people do that, and I think it's actually a great way to communicate.
Right, and you're wanting that because we want the partnership.
Yeah.
That's going to be better for everybody.
Yes. Yeah.
So something I especially admire about what you do is that you're also a teacher, right? So we both work in this academic medical center at UCLA Health. How do you structure rounds, right? So when you're going around and on all of our patients, for the medical students, the residents, so that patients feel heard and not necessarily, presented about?
Sure. And I should say, I can't remember if we covered this or not, for the audience, rounds, you probably hear doctors saying that a lot. That means that we refer to that as when we're going around. I think that's what the word comes from.
Term, yeah.
And we're seeing all our patients. So that may take several hours. You've got 20 patients. You can imagine you're going from one floor to the next, and you're rounding on your patients. I did air quotes there for those who are just listening. But how do we structure it? So like I said, the residents and the medical students will tell me about the patients typically first, and then we will ideally go see them all together in person. And
does that mean that they've pre-rounded before, like they've presented to you before you go into, like
yes,
earlier in the morning?
Yes, they have usually seen the patients early in the morning. We've all looked at all the data. We've all discussed them, and then we will go in and see them all together in person. The sort of, gold standard or holy grail, whatever you want to call it, would be to go in the room with every team member, including the bedside nurse and including the case manager, because then you have everybody hearing the same thing from the patient getting any question they have answered all at once, and they can really put everything together. Ideally, if a patient asks a question from a case manager, a doctor, a nurse, you'd want them all to be able to give that patient the same information, because everybody knows the plan of care. Everybody knows what's going on, and they're on the same page.
Yeah.
So we do our best for that. But as far as for the trainees, again, the residents, I'm using those words interchangeably, or medical students, when we walk in, I introduce myself, I introduce my role, I have everybody on the team introduce themselves again. And for patients, sometimes that may seem redundant. They're sort of like, lady, you were in here an hour ago, or whatever it was. But there's so many people. I never want to make assumptions about what patients may remember. Again, they're sick, they're underslept, and so forth. And then I sort of essentially myself, I do like to ask the patient and hear, with my own words, and hear from them directly how they're doing, what's going on, anything that's bothering them. We examine them. It is, teaching. So if there's some specific physical exam finding, I may ask the patient, do you mind if I have the medical student listen to your lungs, or do you mind if, I have them, examine your abdomen? Obviously, if someone doesn't want that, we absolutely do not. I may say, if I'm doing a little, what we call shop talk, that means kind of, teaching, with medical jargon, I will always let the patient know. Let's say that student examined their lungs, I will tell the patient, I'm just going to, talk a little medicine jargon for a moment while we discuss, what the medical student, heard. And then I will actually turn it over typically to the medical student or the resident, whoever is kind of the primary trainee taking care of the patient, to explain the plan of care to the patient. That may have changed based on that interaction with the patient, or it may be the same as what we spoke about before we came in. And then, of course, we make sure that they understand, and we make sure that they don't have any questions, concerns. What else do we need to address? And I think a lot of bedside education for residents. What that means is, teaching them at the site of care with the patient. There's certainly, there's actually, I think, education for them in everything that I described, how to talk to a patient.
Right, that's the role modeling. Right.
Exactly.
Right.
Role modeling, physical exam skills. But I think the most important thing is role modeling that communication.
Yeah. You learn so much by watching, and
Yeah.
especially when I would have loved to have you as a teacher and and watched you talk to patients, because it's really listening to the words that you're using, how you're talking to patients. I mean, that really serves as the fundamental foundation, right, of then how the doctor, I think, that we all become.
Yeah, and I think, we're taught from early on, there is some, scripted teaching. You remember in like med school or residency, we have like actor patients, and you have to do these like simulated patient encounters. So we all know like not to use medical jargon, and to make to try to make sure that patients understand. But there's all this stuff that gets buried in there that people don't even know. Like they'll use words like, do you feel like you have fluid on board?
Right.
And I hear residents saying that. I'm like, what do you think that person thinks you're trying to say? That means like if somebody has, for example, heart failure and they're retaining water or something.
We do that all the time, especially when you're in a hurry or you're tired. As a provider, you just default into jargon.
Yeah.
And sometimes it's fun. It reminds me that, I love that you do this at the bedside. It reminds me in clinic, so in the doctor's office, when I'm talking to patients at the end of a visit, I'll often just sit with them by the computer and say, look, here's your plan, and I'll write it out together so they can see it. And so we're both involved in formulating the plan. I think that makes a really big difference.
And it's not just, I think, the way you speak, it's also, one's body language.
Yeah.
And, the residents can be taught about that. Sitting down with a patient is so critical, getting at their, eye level and really talking to them.
Having everyone just leaning over you is horrible.
Right. And, you think about how scary that can be for a patient.
Yes.
So also like observing, via their body language or via how they may be, responding, and maybe even if they haven't asked a question, making sure, did you understand what, Dr. So-and-so, meant when they said this, and kind of preempting some questions they may have so you're really looking and making a decision that they're understanding. And, for patients, for families, stop doctors, ask them questions.
Yes.
Like you don't understand, the doctor may not know that. So, as much as you can, ask your questions.
Right. And I think, and it's okay. Exactly. It's okay to ask your questions. And also, something that comes up a lot is communicating to the patients, obtaining consent for even just like touching them, right? I think.
Oh, absolutely.
I think for so long it was just like, I'm just going to put a stethoscope on you and you're just going to sit there. I'd love to hear from you, because when I'm in clinic, again in the doctor's office, no matter what I'm doing, I say, listen, can I place a stethoscope over here so I can listen to your heart, right? Because otherwise people are like, why are you putting your stethoscope on my left breast for no reason?
Yeah.
We just can't make any assumptions.
Yeah.
I don't know if you experience that in the inpatient environment
absolutely.
as well.
And I do think it's a bit more, some people may forget that more in the inpatient setting, and people you're wearing the hospital gowns, and sometimes they're, they're moved down or whatever. I think explaining everything that you're doing to somebody is really critical.
Right.
The other thing that's really important, and I think can come through in a teaching way, but as well as, just generally, physician-patient interactions, is we see in hospital medicine a lot of patients with chronic diseases.
Yes.
These people know their bodies. They have been living with this disease for however long, and every individual is different. So just because, I've read about, whatever, this variant of lupus in this book, this person knows their body.
Yes.
And it is important to teach, and it is important, teach the residents and teach myself, like, you have to listen.
Yes. And and it's the reminder that patients have an enormous amount to teach us.
Oh my goodness. So much.
We had Julie on last week, and she was talking about how she's been enduring stage 4 colon cancer for like 7 years, and she was saying that what she really appreciates about her physicians is when they just admit when they don't know something.
Yeah.
Right? And she knows an enormous amount, So
Yeah.
I think that's such an important reminder, whether you're in the hospital or out of the hospital. Patients, exactly, especially when they've had chronic illnesses, or we can learn together.
Yeah, I actually try to be very clear about that, not just in terms of, admitting if I don't know something. I have no problem doing that at all. But being clear with patients, like, this aspect of whatever it is, it's clear. We know what's going on here. Here's the plan with it. We're really really trying to still work this out. We're not sure what's going on here, because I think for a patient, it's important to understand that. In
Yes.
addition to, I think, a little bit of reassurance of being like, oh, they're not, pretending like they know everything. Like,
One thing I think, we first of all, I love talking hospital jargon because you shouldn't have to go to medical school to enjoy some of it. So one of the words that come up a lot that seem like buzzwords, but I think that they're out there in the mainstream in the news are quality and safety, and those seem like hospital buzzwords. But I think when I think about translating them even for myself, I think about, this is about helping our patients feel better, faster, with fewer complications, and making sure that we as the physicians are catching problems early. And so I'm hopeful that, by educating our patients and listeners a little bit about just a couple of these quality and safety basics, that might help them also just be attuned to better partnering with the medical teams and asking questions. Do you think that these are quality and safety aspects are important for patients and families?
Of course. Interestingly, back to, how we started, the idea, quality really came into medical care only kind of as recently as the late 90s. And by that, I mean really developing a culture of sort of continuous quality improvement, process improvement, and optimizing safety.
Yes.
And hospitalists are actually really at the forefront of partnering with health system administration to develop processes in the hospital to keep people safe. I would love to say that any patient that comes into the hospital only has to worry about getting over their disease. Unfortunately, there's all kinds of things that can happen, in hospitals. Patients can fall and sustain injuries. They can get, infections that they acquire in the hospital. All of these, that's what we mean when we refer to patient safety. We mean keeping the patient safe for all those things apart from their, disease process. Making sure that they get the intended procedure, the intended medication at the appropriate dose. People have heard about the what was that heparin overdose in I forget there was a actor who had his kids got a heparin overdose many years ago,
Which is a blood thinner, right? So
Yes.
got too much blood thinning. Yes.
Right, exactly. So there's all kinds of potential errors, and what we need to do as hospitalists and as health system is understand that we cannot just rely on all humans err.
Right.
That does not make them flawed, but we need to develop systems of care around, humans to make sure that those errors don't reach a patient. So that's why, for example, when you're in a hospital and you get a medication given to you, we scan your barcode on your wrist to make sure you're the right patient. And we also say something like, the nurse will say, even though you've seen this nurse the entire time, they'll say, "Can you let me know your name?" And you'll say, "Eve Glazier."
Yes.
And you might in your head be thinking, why is she asking? Does she not remember my name? Like she's been taking care of me for 3 days. No, it's to make sure that we have a system so you are getting the care that is intended and it's appropriate for you. If that makes sense.
It makes so much sense, and I think it's enormously helpful. I think not only just as an explanation, but it's just reassuring to know that yes, hospitals are very busy, they're complex, but that little tiny misses can really snowball.
Sure.
And so, like you're saying, whether it's a missed allergy, whether it's a medication dosage, but knowing that you as an individual hospitalist, as a group of hospitalists, and then the larger healthcare administration is just constantly, and I know that they are, constantly dedicated to improving the system of care so that these tiny misses don't happen and there's no unavoidable harm.
Yeah. And so when patients should absolutely feel empowered
Yes.
to speak up about anything that they are worried about, anything that's concerning to them. I had a tray brought into my room and it's the wrong type of diet, or, whatever it is. Do not feel that you can't bring that to light. We absolutely want to know about it. And there's a phrase that's used, which is called a culture of safety. And that's something that we really work hard to instill throughout the hospital, which is no one needs to everybody should feel empowered to speak up when they see something that is not going right, to what we call stop the line. It doesn't matter if it's the physician, the nurse, anyone on the care team, the diet tech, the person who's bringing in the tray.
This person's diabetic. This doesn't look like the right tray.
You stop the line, and we all respect that. No one is pointing fingers or placing blame.
Yes.
We are all working together to create systems to keep our patients and our colleagues and everyone who works there safe.
I think while it's a little bit overwhelming to also worry about, like falling and, complications, on the other hand, I think it's so much better just to say, look, these are things, let's name what we're worried about, and let's come up with systems to prevent. There's another word that we use a lot called outcomes, and I think, I don't know if you could maybe go into a little bit of that, and only, especially insofar as that it's helpful to patients and families. I think it would be helpful, just especially kind of some of the levers that we use in the hospital so that the patients do better.
So we were talking before about safety. You also mentioned the word quality. Mm-hmm. Quality correlates a little bit more with outcomes. Safety does as well. But when we think of outcomes, we think about, let's say we track so much data. Let's say for our transplant population, what's our 1-year mortality rate for patients who have had liver transplants? What's our 10-year mortality rate? Same thing for all of our, transplants. We do that for basically almost every, diagnosis. We do it at the hospital level. We do it at the, unit level. So if the outcomes, the outcome is, an example of an outcome would be that, 1-year mortality following a transplant. By that, I mean, essentially the percentage of patients that are still living a year after their transplant, if that makes sense.
Sure.
Same thing for 10 years out, whatever. We want to continuously improve our outcomes. We also want to understand where we're falling short of the outcomes that we anticipate or that we want. And so we need to understand the root cause for those shortfalls and address them. Are we, do we have the same, let's think about something that, might be all over the hospital, congestive heart failure. Mm-hmm. Are we having, worse outcomes on one unit or the other? Mm-hmm. Are we having worse outcomes for some demographic or the other? Are we whatever it is? And then why is that? And how can we address that?
Yeah. I'm just in such admiration. I mean, not only as I think, again, I've been a patient in the hospital, but, my family has too. To know that the hospital's group, the hospital is always just obsessively diligent, right, about making things as good as they can be and then continuously improving, I think is just something that it's really important to share.
Yeah, I mean, and one thing we actually do, this is within my, my own hospitalist group, is we really, going to the outcomes, we really like to learn from each other. Mm-hmm. And so we will essentially, track individual data, even outcome data. Let's say one metric, or metric means like we can think of it as an outcome that we like to look at, is the percentage of patients that we discharge, who we send out of the hospital, who are readmitted back to the hospital within 30 days. We want that number to be low, right? We want them to discharge from the hospital, and we want them to, thrive and do great and not have to come back. If they're coming back soon, maybe we didn't do the right thing maybe we didn't educate them well enough at discharge. Mm-hmm. Maybe there was, some clinical thing that was missed, a million things that could be going on. But we track that across our group, and if we have somebody, for example, has a 7% readmission rate, where the most of the group have a 15% readmission rate, we'll say, hey, what are you doing? How can we learn from you? Let's really hear what you're doing, and maybe we can sort of disseminate it across the group. So We do it at the level of the hospital. We do it at the level of the group, sort of on all kind of levels.
No, I mean, I love it. Those are honestly the best parts of being at an academic center. But the hospitalist group in general, I think, is just a real paradigm, I think, of this model of just getting better and doing better by our patients. Couple myths and misconceptions. Maybe you and I can both go through these.
Sure.
But myth, my primary care doctor will round on me in the hospital. What's the reality today,
In most scenarios, they do not. Like we were saying before, I think that the vast majority of inpatient care now is done by hospitalists. Now, there may be scenarios where your primary care doctor is able to pay a visit. It just kind of depends on the scenario. But I would say, for the most part, that doesn't happen. I did want to mention, it's important, to reassure, though, your audience that it's not like we only touch base with the primary care doctor when the patient comes into the hospital and when they leave. It's really as much as as needed, and often, a phone call is the best way to do it, to really be talking about it. Hey, I'm worried about this. What's your experience with this person? What are you concerned about? Do you have any recommendations for how we might handle that? So it's potentially a ongoing conversation with connecting the hospitalist and the PMD, but an inpatient visit by the primary care doctor, they often can't. They might not be near the hospital. They're in their clinic all day.
That's right.
I mean, you can comment on that.
No, absolutely. I mean, right. So, if my clinic is in where I practice is in Santa Monica, so sure, if one of my patients is hospitalized across the street, what I usually do is, I might go across and visit them.
Right.
And then what I really like to do is remind the patient and their families that my colleague, Dr. Busuttil, is taking care of them. We're constantly in communication, and I agree and endorse your plan.
Yeah.
You know what I mean? So that everyone feels reassured. We're all on the same page, and then I'm ready for you when you're discharged to come see me as follow-up once you're out of the hospital.
Yeah.
And I do think that, that endorsement, that community endorsement helps. But now, granted, the Santa Monica Hospital is right across the street from the clinic where I practice. Right. But, here at UCLA, we have like 290 clinics. They're all over the place. So that's not always feasible. But that's where I think patients might be reassured to know, as you were mentioning, we have part of the electronic record is I can actually see the patient's vital signs, the nursing notes, X-rays, everything that's done in the hospital, and I can see, and I say I'm following along as well.
Yeah.
How do you build trust? So I have these longitudinal relationships as a PMD, primary medical doctor, PCP. How do you build trust with patients? Because that's some of the myths, which is that, this hospital doesn't know me well. How are they going to care for me?
Yeah, it's tough, right? Well, first of all, we've talked so much about communication. The most important part of that communication is listening.
Yeah.
So that you really need to, listen to a person's concerns and what's going on with them, and you really need to, that's part of also sitting down, spending, the time that can be, and, making sure that, I think it's a lot of everything we talked about, explaining, making sure we're both agree what the goal of our hospitalization is. It is, though, it's a skill that hospitalists really need to, learn and continually work on, because you've got to get in there immediately. You don't necessarily know this person. They're in this really, potentially really vulnerable and potentially critical state. And you got to get in there and quickly have hard discussions with them, So I guess I don't have an easy answer for that one, other than really making sure that you have a well-functioning, bi-directional, open lines of communication with them. And sometimes you can't just jump in and be, heavy-handed with stuff. Maybe never you should be heavy-handed, but, everybody's different. Everybody's had different experiences with the medical system.
Yes.
Some people, have had really bad experiences, and they have a lot of, earned distrust, right? So you need to just be thoughtful and, careful with those relationships.
That's an amazing answer. One thing I just wanted to emphasize, and you've said this, but the myth is that here's a myth, discharge means I'm 100% better.
No.
Yes.
It does
not. So the realistic time frame. Yes. Yeah.
And I think, people can even think if they've had, for example, experiences with, like let's take childbirth, you
Yeah.
know, which is a, you know, normal, you know, kind of hospitalization, and maybe not, but, you know, you don't feel great when you get home, but also, like most people, I think they do want to get out of the hospital.
Yes.
So, yeah.
I have to tell you, it's amazing to sit across from you. And yes, having known you, you know, since you were like 12 years old, and I'm like, oh my God, now you're this just an incredible adult. I'm just going to say it. Like, you're an incredible
Right back at
physician
ya.
and teacher and just person. I am curious, you know, from dance team to residency to now, but why did you become a hospitalist?
I mean, I was never the kind of person who knew exactly what I wanted to do. I think I became a hospitalist because I do like, from a, you know, what I'm interested in medically, I do like the sort of more acute medical illnesses. I like being able to sit down and empathize with people when they're in that vulnerable state, and I hope make them feel, you know, comforted and safe. I think it is such a privilege to really like bear witness, to be allowed to bear witness to people when they're you know, kind of dealing with that. I mean, it's just it's really kind of profound. And then, you know, on maybe a less, you know, emotional level, I met physicians, mentors who I admired and decided to do what they did because I admired them. I mean, that's kind of how I figured out some of my career trajectory, whether it be on the, you know, clinical side. By that I mean the medical, you know, taking care of patient side, as well as, you know, the administrative roles that I do as well. So.
We have a segment called From the Rooftops. So if what would you want to shout from the rooftops, I guess, or wish that every patient and family knew who are going into the hospital?
Your doctors are really there to help you as much as they can and be your partner. You know, they can't help you unilaterally. You know, it's a partnership. You know, we want to work together, you know, with you for whatever it is that your health goals are. And if we're on the wrong page, you let us know. Like, we need to be on the same page, and so we need that feedback and that partnership.
Incredible. First of all, I want to thank you for coming on the podcast today. I think you've made hospitalist care totally make sense. I also just want to thank you for the incredible role that you play at UCLA Health every day. Honestly, I shouldn't be surprised, but, you know, sometimes when you're close to someone, you just don't realize, or not that you don't realize, but you're just so exceptional. I mean, your patients are so lucky to have you, the trainees as well, and I'm done complimenting you now. But I think it goes without saying that if I'm ever admitted, you're taking care of me.
I will take care of you.
Drive you crazy. I will page you nonstop,
Yes.
text you. But thank you for coming on today and walking us through this. To our audience, I want to say thanks for listening. Please share this episode for anyone navigating a hospital stay right now, or honestly for all of us. I think all of us will be in a hospital at some point.
Yeah.
Any last words?
Thank you so much. I am equally impressed. Some people drift apart after decades, but not us.
Not us. We actually share a wall, and we dress the same. I'm Dr. Eve Glazier. This is Medically Speaking. Thank you, Ashley, so much.
Thank you.